So welcome to this lovely space in the Wethington building. My name is Erin Haynes, and I'm new to UK. I'm currently the chair of epidemiology in the College of Public Health, and also interim chair of preventive medicine and environmental health. And I have the great privilege today of bringing in our inaugural environmental health sciences speaker. At UK, we have a phenomenal resource. It's called a P30. It's from the NIEHS, National Institute of Environmental Health Sciences. It's an environmental health science core center. There are about 20 or so of these across the United States. And Mount Sinai also has one. We partnered with them in my capacity in Cincinnati before I came, but also now here in Kentucky. And so we've invited, as part of the review of the Department of Preventive Medicine and Environmental Health, and also as our inaugural speaker of environmental health sciences, Dr. Robert Wright from Mount Sinai. He started this Institute for Exposomic Research at Mount Sinai and is doing some of the most forward-thinking, cutting-edge environmental exposure science research across the nation. In fact, we'll just go big and say it's across the globe because, of course, it's the best. So we're so glad to have him here. He's been a mentor and colleague of mine for over a decade. And I owe my first grants to his consultation and mentorship. So I'm so pleased to have you here, Bob, and we look forward to hearing your talk. Thank you.
Thank you. It's really nice to be here, and I'm really honored to be the inaugural speaker for your P30 Center. So this is where I was this morning, New York City, Mount Sinai. Will this work? Mount Sinai are these buildings in the front here. This building right here is where my office is. It's the ugliest of Mount Sinai buildings, but it goes about 4 blocks north and about 1.5 blocks wide. So that's our entire campus. But it's, it's very vertical. A lot of these buildings have 20, 30 floors. So we make up for some of that space vertically. That's a very common Manhattan thing. And that's Central Park on the right. So whenever I get stressed out, I can take a walk next door or across the street. So I'm going to talk to you about exposomics and precision medicine. And I'm going to try to challenge some assumptions about precision medicine, but also about environmental health. And I'm going to argue that probably nobody at the University of Kentucky, nobody at Mount Sinai, in fact, almost no one, probably not zero, but almost no one in the country is actually doing exposomics or environmental health and precision medicine. And then the subtitle of the talk is Everything That Rises Must Converge. If there's any English literature majors in the audience, they might recognize who Flannery O'Connor is, but they also might be confused because of what that story is actually about. But I won't go further than that, but I like the title. So what is precision medicine? So the National Research Council defines precision medicine as the tailoring of medical treatment to patient characteristics. That is, the goal is to create susceptibility subclassifications to disease, its prognosis or response to treatment, so that we can individualize interventions, maximize benefits, reduce treatment failures, and reduce side effects. It really means we want to understand each individual patient's background and how that background influences the progression of the disease and treatment response. It operates in a setting where the probability of illness is 1. Prevention no longer matters. I understand that this is a public health audience, so that may be a little bit different for you, but I'm going to come back to why that's important and why that opening statement I said where almost nobody's doing precision medicine in environmental health or exposomics, it's because almost nobody studies disease in public health in this probability of illness equaling 1, and almost no one in medicine studies environmental health. So I defined precision medicine. I should probably define exposomics. It might be a new term for some folks in the room. It was coined in 2005 by Christopher Wild, who's now the director of IARC, the International Agency on Research in Cancer. And he defined it as an analog to genomics. So it's a study of all health relevant environment across the lifespan from conception until death. So unlike your genes and your DNA sequence at least doesn't change over time, your environment obviously changes relatively dynamically, but that doesn't mean we can't capture the most important pieces, those health relevant pieces. In environmental health, we tend to be thought of as toxicologists, but it's not really just chemicals. Exposomics would include the social environment, the nutritional environment. I don't think this really works. And the physical environment as well as the chemical environment. So it's all of these things and how they interact with our genome. So coming back to precision medicine, the current practice of precision medicine is really a pharmacogenomic practice. The idea is if we understand genetic variation to treatment and disease, we'll increase drug efficacy, decrease toxicity, decrease exposure to ineffective drugs, target therapy to the most effective drugs, and possibly even target behavioral modifications based on your genetic risk factors. The idea is that we'll be able to improve counseling and decision-making, both for physicians and patients. We'll improve patient outcomes and satisfaction. We'll improve tolerance of therapy and therefore improve adherence to therapies. But in reality, this will only work if genes are the only source of variation in treatment and prognosis. And in fact, if you were to look at precision medicine websites, and I downloaded or copied a few websites from different institutions across the country, I'm pretty sure Kentucky's not on this, so it's not the most flattering description that I'm going to give, but precision medicine, if you look at these websites at institutions across the country, they always have a picture of DNA. They always have some statement about genes causing disease. Genes actually don't cause disease independently, and I'll go over that in a few minutes. And I'm going to stand by that statement. I know there's probably some geneticists in the room who will disagree. Environment doesn't cause disease directly either. They always interact. And then you'll do, if you understand your genetics, you'll get gene-targeted drugs so that you can have all those benefits that we talked about in the previous slide. But we know genetics is only one piece of a much bigger puzzle. Yet if you look at these, most programs in precision medicine do not mention environment. Here's another one. It has a nice pretty picture of DNA and drugs and how it's going to stratify people into different subclassifications, and that's going to make everything better. And here's another one which basically does the same thing, which is another picture of DNA. But the only thing that varies is how they depict DNA. Yet we know that it's not all the genes. And in fact, in 2002, this was the cover of Science. The complex diseases, those are the important diseases from a public health perspective. In the 20th century, it was really about hygiene. It was about infectious diseases and mortality. People were dying from infections. Now that that's basically been fixed in developed countries, we have the morbidities, what David Savitz actually once referred to as the new morbidities. These are diseases like asthma, diseases like autism, diseases like COPD and Alzheimer's disease. These are what we call complex diseases. They're the major drivers of healthcare costs in the United States. And their etiology is actually a mixture of all kinds of things. Genetics clearly plays a role. But so does behavior, so does nutrition, so does infection, so do chemicals, so does the physical environment, things like air pollution or the built environment, so does culture and society and psychosocial stress. All these things play a big role in complex diseases. And in fact, the introduction to this special issue in Science was called It's Not Just the Genes, which was an editorial. And this was in 2002. So precision medicine somehow moved from this in 2002 to a purely genocentric perspective on how diseases occur. So for those who are Talking Heads fans, so how did we get here? So as I said, we're interested in complex diseases, things like attention deficit hyperactivity disorder, obesity, asthma, COPD, Parkinson's disease, cancer. All these things are complex diseases. It's a short list. It's much, much longer, the real list of complex diseases. We know that their etiology is a mixture of genetic and environmental risk factors. When I say environment, I'm talking about environment broadly, as I defined it earlier, about chemical, social, physical environment, as well as nutritional environment. Why is this thing moving? They're rising in prevalence and annual incidence. Genetic main effects cannot explain rising rates of disease. So everyone's probably heard about the autism rates rising over the last 20 or 30 years. That can't be due to gene. Even if you think autism is 100% genetic, and I would probably argue that it's not, But even if you believe that, it cannot explain a rising rate over 20 to 30 years. That's one, maybe two generations. We're not the X-Men, we're not mutating. So the rate increase cannot be due to genetics. And even other diseases, other than autism, they're also going up. Certainly obesity is going up in the United States. Asthma is going up, COPD is going up. Multiple diabetes is going up. Type 1 and type 2 diabetes are going up. Genetic main effects cannot explain any of those rising rates. They're too fast. Environmental risk factors, however, that are driving them, because we know it has to be environment, because it can't be genes, and if it's only one versus the other, it has to be the environment that's driving the rate increase. We don't know very much about them. And in fact, I would argue that too much of our research thinks of nature versus nurture. In fact, heritability estimates, which I think have done a lot of harm because they've conceptualized diseases as being either genetic or environmental and that they're independent, when in fact they always interact, have actually made it harder to do the kind of research that we need to do if we really want to understand what's going on. Because genetics is not really causative, it confers risk. There's a capacity of risk that gets set off by the environmental triggers. And by the same token, environment works on a genetic background. So if you get exposed to something, you're going to have a variable reaction to it, dependent in part on your genes. So neither one of them are really independent. So we're going to take a step back and think about, why do we even call diseases genetic or environmental? And I'm going to argue that all diseases are due to gene-environment interactions, and our perception is actually driven by the prevalence of the genetic factors and the prevalence of the environmental factors in the population. If the genetic factor, the genetic polymorphism, is low in prevalence in a population and the environmental factor is very, very common, our perception is that that disease is genetic. By the same token, if the converse is true, if the environmental factor is relatively uncommon and the genetic polymorphism is very high in prevalence, that disease will appear environmental. This is a difficult concept to illustrate in people, but it's actually easy to show in chickens. So there really is a trait called yellow shanks. And yellow shanks is a discoloration of chicken legs if the chicken carries a particular genetic variant and it eats yellow corn as opposed to white corn. This is an example that Ken Rockman gave in an article once. The genetic factor follows an autosomal dominant transmission pattern, or inheritance pattern. So imagine two farmers, Farmer Jones and Farmer Smith. They live down the road from each other. Both of them have inbred chicken flocks. Farmer Jones' chicken flocks all has a variant for yellow shanks. He's been feeding, or his family's been feeding them white corn for generations. Yellow shanks brings down the price at market. They don't want them to have yellow shanks because they'll make less money. One day the store runs out. He has to feed them yellow corn. Every chicken will get yellow shanks because they all carry the variant for yellow shanks. If you were to ask Farmer Jones, is yellow shanks an environmental or a genetic trait, he would say it's an environmental trait. It's caused by yellow corn. Down the road, there's Farmer Smith. He has an inbred chicken flock. None of them carry the variant for yellow shanks. Yellow corn's cheaper than white corn. His family's been feeding yellow corn to their chickens with impunity for generations. Nothing ever happens. And then one day, one of the chickens gets yellow shanks. He's an amateur geneticist, and he says, he finds out after he draws a pedigree that half of the offspring of that chicken get yellow shanks. And he draws this large pedigree over multiple generations, and he reaches the conclusion that yellow shanks is a genetic disease that follows an autosomal dominant pattern. From a biological perspective, the exact same thing is happening in Farmer Jones' population of chickens as Farmer Smith's. But the perception is completely driven by the prevalence of the two traits, environmental and genetic, in the populations. And that's what's happening in humans. It's harder to see, but under this scenario, is yellow shanks genetic or environmental? It's completely contextual. It depends on the prevalence of the environmental factor and the prevalence of the genetic factor, and they interact. By the same token, if we believe this is happening in humans, and it clearly is, you can think of any genetic disease, and you can probably come up with what the environmental factor is that's actually driving it. And if it's really, really common, cystic fibrosis, it's hard to avoid sodium. It's about the sodium-potassium pump. It looks genetic because the environmental factor is so common. Hemochromatosis, which is something, a disease in which you hyperabsorb iron. If you're a vegetarian and you carry the genotype for hemochromatosis, you don't get it. It's completely driven by both the prevalence and the environmental and the genetic factor. You can actually modify it. Phenylketonuria, which we think of as a genetic disease, we can actually modify it by changing the diet if we know what the genotype is. So even diseases that we think of as purely genetic have environmental components. In fact, under this scenario, what is the real heritability of chicken shanks? In one scenario, it's 0%. In the other scenario, it's 100%. This is why I think heritability estimates actually do more harm than good, because everything is a gene-environment reaction, because all genes operate in variable environmental backgrounds, and all environmental factors operate in variable genetic backgrounds in populations. And there are a lot of backgrounds. There's nutritional backgrounds. If I give you a drug to treat something and you're obese and it's a fat-soluble drug, it's going to behave differently than if you're not. And your genes will not detect that, because we're talking about metabolism of the drug. By the same token, if you have a vitamin or mineral deficiency, that may actually increase the probability that you don't have a cofactor for metabolism drug. Health states change metabolism. 30 years ago, when I was a pediatric intern, we used to give theophylline to kids with asthma. Not done anymore, but during flu epidemics, there would actually be an epidemic of theophylline toxicity, because influenza actually changes your metabolism of theophylline so that you could metabolize it as well. So the correct dose for weight actually could lead to excess of theophylline and actually theophylline toxicity. So health states also change the way that you metabolize drugs. There are obviously differences between sexes, on how people metabolize drugs, and states like pregnancy can also affect drug metabolism. Geography and culture affect drug metabolism. If you live in the mountains and you're 1.5 miles in the sky, your hemoglobin is going to be higher. Your risk of stroke is actually a little bit higher, because there's a slight increase in viscosity if your hemoglobin is slightly higher. And then there's also mixtures of chemicals that can impact drugs. If you drink a lot of grapefruit juice, you might inhibit your P450 system. That might inhibit your ability to metabolize a drug. All of these factors are things that can affect treatment that will not be picked up by DNA sequence variation. This is why we need to start thinking about these sorts of things if we're really going to make precision medicine precise. Exposomics, as I said, it addresses all of these different environmental backgrounds. Let me give some examples. This is the classic pharmacogenomic example for precision medicine. So a 53-year-old woman develops a DVT, a deep venous thrombosis, on a trans-Pacific flight. She develops a GI bleed after starting a standard dose of warfarin, warfarin being a blood thinner. Do you know why that happened? She carries a genetic variant in the P450 system that actually reduces the metabolism of warfarin, so she needs a lower dose. It's a well-described thing in precision medicine. It is actually on every one of those websites I showed before as an example of what precision medicine will do. It's a real thing. It's a real benefit that people have. But here's another scenario. A 17-year-old child with autism has a notable increase in head banging and anger outbursts. So what do you think might be causing that? So what's unusual about this situation? He's 17 years old and he has lead poisoning. Anybody here knows anything about lead poisoning? You never see it in a 17-year-old. You see it in a 2-year-old, because 2-year-olds have a lot of hand-to-mouth activity. 17-year-olds don't, with one exception, at least one that I know of, autism. Kids with autism tend to have pica. They tend to put things in their mouth. He turned out to have lead poisoning. He had pretty severe lead poisoning. His blood lead was 73 micrograms per deciliter. He had a 3-year-old brother who did not have lead poisoning. It was his autism. It was his disease state that actually predisposed him to lead poisoning. Actually, we treated him. It turned out he used to eat newspapers. This is the 1990s. I'm dating myself. Nobody reads newspapers anymore, so it wouldn't happen anymore. But newspaper ink, back then, I worked in Boston. Back then, the newspaper ink in the Boston Globe had lead in it, apparently, and that's what he used to do all the time, and that's how he got lead poisoning. So once the family was able, they canceled their subscription, and they were able to get other things out of the house that might have ink in it. They were very vigilant about that, and he didn't get lead poisoning anymore. Here's another example. A newborn infant in rural Iowa is cyanotic. He's blue, but he's behaving normally. In the usual scenario, that might be congenital cyanotic heart disease, but that's not what he has, because he has a referral to a pediatric cardiologist. He has an echocardiogram. He has a normal heart. Does everybody know what he has? He has something called methemoglobinemia. So methemoglobinemia is an oxidative state of hemoglobin that actually cannot bind oxygen. So you look cyanotic. It won't oxidize all your hemoglobin because so you can still survive, but you'll look blue. And babies, newborn babies, actually the enzyme that reduces methemoglobin back to normal hemoglobin is called NADPH, methemoglobin reductase. It is poorly expressed in the newborn state. So the clue is he's a newborn infant, so he's very young, he's not expressing it, and he lives on a farm in rural Iowa where there are nitrites in the well water, which they were using to mix his formula. So he's getting exposed to nitrites. Nitrites are powerful reducing agents. So that's why he got methemoglobinemia, even though his siblings who were slightly older than him did not, because they had fully expressed methemoglobinemia reductase. So a 14-year-old with gastroesophageal reflux is treated with morphine because he has a fracture and he gets respiratory failure. So they gave him too much morphine, but they gave him a proper dose. So what was going on with him? So he has GE reflux. So he's taking over-the-counter Tagamet, which is a P450 inhibitor, and maybe he's also drinking a lot of grapefruit juice. So he's inhibiting his P450 system, so he's not metabolizing morphine normally, and he needed a lower dose. So all of those examples would not have been detected by DNA sequence except for the first one. All those examples of how precision medicine can benefit by including environmental risk factors in the history and the physical, so that we can better understand what is actually happening, because our environment does play a big role in our diseases, even when it interacts with genetics. So medicine, I'm going to argue, and I'm a pediatrician, is a genocentric science. Most of the residencies and the deans, including my own, actually think that genetics is the most important thing in the world for young students and trainees to study. And I actually did study genetics at one time. I did a postdoc in genetic epidemiology, but it's not the whole story. We have to keep going beyond that if we're really going to understand how people get sick. Medicine and precision medicine largely ignore environmental contributors to disease, including disease mechanism, diagnosis of disease, and response to treatment. But I'm going to make a counter argument that public health, and I'm a public health scientist myself, we're an envirocentric science. Particularly if we think of the exposome, we think about nutrition, we think about social variables and physical built environment. We tend to think of that only, more so than genetics. And we largely ignore the role of environment and how it impacts response to treatment. We also ignore that, or don't take into account that probably the largest susceptible population in this country to environmental risk factors are people with a disease, because we're getting sicker as a population. More and more diseases are occurring, and those diseases are impacted by the environment that we're living in. And we don't study that and how that affects the disease. What I'm saying is people who already have a disease, that probability of a disease equals 1 that I put on an earlier slide, they get exposed to phthalates, they breathe air pollution, they have all those environmental chemicals that we talk about in their system, and it's affecting their disease, but we actually never study it. It is incredibly unusual to find a study that actually looks at people with a disease and how they're affected by air pollution or even lead, which we know more about than any other environmental chemical. It is almost unheard of to see a study that actually looks at that. And in fact, as I said, they're the largest vulnerable population of environmental exposures in the country, the people who already have a disease. So basically, medicine and public health ghost each other. We don't talk to each other. We each think the other side isn't doing the important work and that we're doing the important work. So we need to figure out ways to come together. And I think precision medicine might be one of those ways. So this is the medical perspective. I want you to help me diagnose a patient if you're going to do research. In that context, environmental epidemiology or exposomics and epidemiology might help because risk factors are kind of weighted variable. If you come in with chest pain, you're 55 years old and you're a smoker, I will probably take seriously that this is, very likely to be a heart attack. Help me to treat the patient. Environmental epidemiology or exposomics epidemiology doesn't really help. If you already have lung cancer or you've already had a heart attack, I'll tell you to stop smoking. But that doesn't affect what I'm going to do to you. I'm still going to give you nitrates for your heart attack. I'm still going to potentially do surgery if you need it or do a stent. All those things happen independent of the fact that you used to smoke. Other than telling you to stop, it doesn't actually impact anything. And yet, there may be things in your diet and your behavior that we could intervene on. Just like we tell you to eat a low cholesterol, low sodium diet, there may be things you should be avoiding in your environment that may also prolong your life after you've had a heart attack. And we don't study those. So Ursula K. Le Guin, who's a science fiction writer, there are no right answers to the wrong questions. I would argue that environmental health and precision medicine aren't asking the right questions of each other. So we're not asking questions that are relevant to medicine. In public health and in medicine, we're not asking questions about environment, even though environment plays a very big role in all diseases, even genetic diseases. So what are the roadblocks? So medicine thinks about the individual. It thinks about diagnosis, the certainty that a problem exists. So if you're a physician, somebody comes to you, you may not know what the problem is, but the fact that they came to you means there is a problem. So we need to understand diagnosis better. And then once we understand what we think the problem is, we need to come up with a treatment, reduce side effects, and have the best outcome possible. In public health, we think at the population level, not so much the individual level. We think about risk factors. If you get exposed to something where you get sick, if you eat a low cholesterol diet, are you less likely to get a heart attack? That's not a probability of one scenario. Very different than what the physician faces. Physician faces a scenario in which somebody has at least symptoms. If they don't have an exact diagnosis, so they may actually have the diagnosis. In public health, we're looking at healthy people. We're trying to prevent them from becoming sick. So there's a probability issue of whether or not an illness is going to occur. And we're thinking about prevention. We're not thinking about treatment. And we're thinking about susceptible populations, although, as I said earlier, probably the most susceptible population are people who already have a disease. Medicine starts after the person gets sick. Public health starts before. Public health wants to discover why and to prevent the disease. Medicine really isn't interested in why you got sick. I'm brutally honest, when I was a physician working, I was an ER physician for many years, pediatric ER, why you got sick wasn't as important as what do I do next? So we're interested in how to treat a situation that already exists. So from a research perspective, it kind of looks like this. So if the x-axis is time, is this showing? So if the x-axis is time, I don't know why it looks like it's doing something here. Oh, was it working? Briefly? Well, okay, the x-axis is time. And so the little notch is when somebody gets a disease. So public health research tends to occur before that notch, in the time frame before that notch, whether it's a prospective cohort study or whether it's a case control study, it's happening on the left side of the notch. Precision medicine research, I'm going to argue, needs to happen on the right side of the notch, after the disease occurs. So we have to link to randomized controlled trials or do clinical observation studies if we really want to impact medical treatment and impact precision medicine. So public health, on the left side of that notch, is interested in causation and risk factors. On the right side, medicine is interested in diagnosis and treatment. Precision medicine studies, if we're going to start doing them, have to begin after the disease has started and move forward in time. And that's why I say that very few studies actually look at environmental risk factors on the right side of that graph. They almost always occur on the left side of that graph. It's almost completely wide open space. So what are the most important backgrounds in precision medicine? I'm going to argue it's not actually genes or environment, despite all my talk about genes and environment, but it's disease and treatment. We have to reorient ourselves to think about what happens when somebody already has the disease. We have to understand the pathophysiology of the disease so we can understand how the environmental factor might impact it. And we also have to understand what the treatments are. In fact, remember that early example that I gave you of the DVT, the genetic risk factor that was actually causing that woman to have the complication from warfarin had nothing to do with why she got the DVT. It was actually a reaction of the treatment, warfarin, that it was interacting with. So it didn't make her at higher risk for the DVT. It gave her a higher risk of having a side effect from the treatment. And that's actually very, very different. And that's a reorientation that we all need in public health. We need to start to understand treatments better. if we're going to do this kind of work. So we need to do the kinds of studies that physicians need in order to treat patients. And I'm going to argue again that we're not really doing that right now. There are very few examples. However, I do believe that exosomics can operate in the medical world. I think largely, for whatever reason, we've been ghosting, each side has been ghosting each other, and we haven't really even tried to look at how environment impacts disease, diagnosis, treatment variability, side effects, or progression and prognosis of a disease. So I'm going to give an example from one of my faculty of a type of biochemical marker that actually can go back in time. So his name is Manish Arora, and he's a dentist and a chemist, and he developed a biomarker using deciduous teeth, which are baby teeth. Teeth have growth rings in them like a tree, and using sophisticated ICP-MS laser ablation with mass spec, you can actually measure the amount of an element inside these rings. And the rings can be dated because there's a ring that's formed on the day that you're born called the neonatal line, which looks histologically different than all the other rings. So rings on one side are prenatal, rings on the other side are postnatal, so he can attach dates to relative concentrations of these elements. And he's applied this in autism. So he got some monozygotic twins who were discordant from autism from a cohort study in Sweden, and he measured lead, manganese, and zinc in their teeth. And again, on the there we go. On the x-axis is time. So this dotted line is roughly the day the children were born. And the minus numbers are events that happen or concentrations of lead, manganese, or zinc that occurred in pregnancy. And then the positive numbers are postpartum. So you can see that in these monozygotic twins who are discordant for autism, that is one twin has autism, the other doesn't. They're genetically perfectly matched, same DNA sequence. There is higher lead in the twin with autism postpartum than the twin without autism. And there's lower manganese in the twin who has autism prenatally, and lower zinc in the twin who has autism prenatally. And these were statistically significant. So I'm going to ask you a question. I'm going to ask you to raise your hand and vote. How many think that this is a good example of a precision medicine environmental health study? I'm going to ask you the other vote too. How many think that this is not a good example of a precision medicine environmental health study? How many aren't sure? I think that's actually the right answer. So the greatest value might be in diagnostics. However, your teeth fall out when you're 5, and you've already been diagnosed typically by the time you're 5. He's starting to look at this in people with schizophrenia. Schizophrenia doesn't present till you're 18, so potentially it could be pre-diagnostic. But does it really affect treatment options? You can't go back in time and chelate the lead, because this happened in the past. You can't go back in time and give the manganese supplements in pregnancy, because this happened in the past. So I think it's an open question whether it really has an impact on precision medicine or not. I think it might have some diagnostic value for some diseases like schizophrenia, but whether or not it actually is important for treatment, and I think this is fantastic stuff. It got published in Nature, but it's not precision medicine. So the public health perspective, time travel helps because we're thinking about prevention. So you want to go back in time and see what caused the disease. And we're looking at causation. We're trying to figure out what causes these. There's lots of causes. For the epidemiologists in the room, a lot of phenotypes have subphenotypes. Autism isn't one disease, it's multiple diseases. And when you do a big epi study, that actually reduces your power. And that's true for a lot of diseases. Alzheimer's isn't one disease. Parkinson's disease isn't one disease. It's multiple disease. So you actually dilute your power because you're lumping people together that don't actually have the same disease, which may have different causes. So that's a problem in causation research. Also, you have to counsel people at the population level, and healthy people don't listen. Okay? You know, you can tell people that they should eat a low sodium, low cholesterol diet and exercise every day. Most people don't do that because they're not sick. They're pre-illness. Healthier people are much also harder to recruit and retain. There's nothing in it for them from their perspective. So it's actually much harder to do a cohort study on healthy people or get controls. Everybody who does a case control study will tell you this. It's a lot easier to get the cases and the controls. The reason is the cases want to know what's happened to them. So they're eager to join a study. Controls don't. They don't care. So it's much, much harder. So anytime somebody comes to me and says, oh, we're going to get all these cases, that's great. I always say, well, that's easy. The hard part is finding appropriate controls and getting them to agree. The medicine perspective is different. Time travel isn't really necessary in a precision medicine paradigm. In fact, I want to know what's happening right now while you have the disease. So that's actually an advantage. I don't have to try to go back in time. I just want to know right now while you're sick what you're exposed to and how it might be impacting your prognosis and response to treatment. Causation is irrelevant. You have the disease. In a sense, it doesn't really matter how you got the disease. And in fact, I argue that non-specific phenotypes, that problem when you're trying to do causation research may be completely irrelevant in precision medicine. Because you may have a subphenotype for diabetes, but if phthalates, which are thought to be an endocrine disruptor, are affecting your glucose, it doesn't matter which subphenotype you have. In fact, it may affect all the subphenotypes equally, or it may have some greater effects on one than the other, but it actually may be less important than it is in causation research. And you also counsel people at the individual level. Sick people will listen to you. My father had a massive heart attack when he was 49. He was a smoker. He was overweight. He never exercised. All three of those things changed immediately, and he lived another 26 years because of the heart attack. So sick people will actually listen to you. They also want to join studies. So if you want to do a cohort study of people with the disease, you're going to have a lot easier time recruiting them, and they're going to come back because they want to know what's going on. They want to know about their health. There's real incentives. So I actually would argue that precision exposomics or precision environmental health is going to be a lot easier to study than causation research, the precision public health. So why now? So we've been able to do this for a long time. Well, actually, maybe not. In fact, I would argue that there have been enormous advances in exposure science in the last 10 years that actually comparable to genomics, but probably haven't gotten the same attention in the press. We now do untargeted chemical assays. So at Mount Sinai, we have a CHEER Center, Child Health Exposure Analysis Resource, where we do untargeted chemical assays. This is where we look at with high resolution mass spec across the entire chromatogram to assess what we call features, which represent thousands of chemicals. We can assay them, and we can get a semi-quantitative estimate of their levels across urine, across plasma, or virtually across any kind of tissue that you can collect. We also have high dimensional targeted chemical panels. In our lab, we can measure roughly 250 chemicals on 3 to 4 panels. That's very analogous to where genomics was 15 years ago with microarrays. So if you remember when genomics started after the Human Genome Project was finished around 1999, most of the genetic studies were still doing PCR RFLP at that time. And then they started doing sequenome and these microarrays. It started going from hundreds of SNPs to thousands of SNPs to hundreds of thousands of SNPs to millions of SNPs to whole genome sequencing. That process is starting in environmental health. We're starting to measure panels which are analogous to microarrays and are measuring hundreds of chemicals. Pretty soon it's going to be thousands of chemicals. So that's going to happen in the next 5 to 10 years because that's where all the growth is going to be in omic research. Then there's satellite remote sensing. There are satellites circumnavigating the globe that are measuring lots and lots of things. Much of it is publicly available. And you're able to actually, if you know where somebody lives, you can actually do estimates of air pollution, temperature, green space, light at night, all kinds of environmental variables using satellite remote sensing. People are publicly mining databases like the Census Bureau, but also other types of databases within cities to get a sense of the built environment, walkability scales, access to healthy foods. All those things are actually now available through public database mining. The electronic medical record can now be mined. Almost every hospital now has an EMR, and that is a source of environmental data. What drugs you're on, where you live, all that stuff can be downloaded from an EMR, and it can be linked to the other types of satellite remote sensing variables as well. Wearable devices like my iWatch are becoming more and more common, and some of them actually measure environmental chemicals. And that's going to become more and more common, measure physiologic measures that you can link. And plus, Apple knows where everybody in this room who has an iPhone is right now. And if you've got Google Maps on your iPhone, Google knows where you've been. You don't even have to have it open. When you clicked, you agree, you signed yourself up for all of this. And they know everything about you. And so it is doable. Obviously, it's a bit unfair that we have to ask for informed consent and Apple and Google don't. And that gives me pause. But But the ability to link where you are to these satellite remote sensing and other types of measures is greater than it's ever been. And the computational infrastructure to do that exists now. It didn't exist 10 years ago, but it exists now. So this is an example of untargeted chemical assays. I think these could be used in, to aid in diagnostics, maybe in a case control or cohort study, where you have people who have a disease and people who don't. Basically, it's a high-resolution mass spec screen where you're looking at all these peaks in a chromatogram. These are referred to as features, and these features actually represent chemicals. Some of them represent noise. It's a little trickier than I'm saying, but the larger the peak, the less likely it's noise. But the exogenous chemicals are things like phthalates and BPA and these other organic chemicals are probably these smaller peaks. The endogenous metabolites are in large part these larger peaks. But as the resolution gets better and better, we're going to be able to, and the libraries get bigger and bigger, we're going to be able to identify more and more of these smaller peaks and what they are. And that's actually going to, that's actually occurring right now. And in a case control design, you may actually be able to find a signature without even knowing what the peaks actually are, but if it's a reproducible signature of chromatograms, you could actually perhaps even have a diagnostic set of features for a particular disease. As I said, case control studies for untargeted chemical screens might be useful for diagnosis, but you could also run them prospectively in cohorts of patients to get an idea of whether or not there's a particular set of features that actually predict poor response or early side effects. You can actually do this potentially on existing samples if you can partner with somebody who did a randomized controlled trial and collected these sorts of biospecimens. Study design matters when you're applying exposomic data. So you have to look at people who have already had the disease. So you're probably not going to be able to do this in a lot of public health observational epi studies because they didn't follow the people after they got sick. You sort of stop at that point, oftentimes in epidemiology, certainly in case control studies, that's what happens. So we're going to have to require either new partnerships or partnering with people who do randomized trials. And there's wearable devices. Many of you probably are aware of the Internet of Things, where you might have a sensor that connects to the internet and downloads all the data. Your iPhone is part of the Internet of Things. Fitbits are part of the Internet of Things. There are phone apps. They're in your car. They're in appliances. These are often referred to as effectors. They enable objects to exchange data through the internet with other connected devices. They get downloaded and they usually get linked to GPS, global positioning satellites, so that we know exactly where you are when you were running, exactly how much air pollution you're breathing in at that rate, and a lot of your eye watches, because you can actually tell your breathing patterns from your blood pressure plethysmography. There is a pattern in your heart rate that actually follows the respiratory rate, so it actually is possible to get your respiratory rate from your heart rate. And then there's sensors being developed that are going to measure things like your electrolytes in your sweat and other things like glucose in the sweat that you could actually put on people with diabetes to get a sense of whether or not they're having some early diabetic ketoacidosis or poor control of their diabetes. Right now, most wearable device research is being done in healthy people. It doesn't help that much in disease management, but if we put them on sick people, that might actually tell us something different and interesting. Maybe it'll help us track response to treatment or disease progression. If you have Parkinson's disease, maybe some of these actographs can actually tell you how active your patient is and whether or not that's actually prognostic of whether or not the disease is progressing faster than people who aren't doing that. And it doesn't require multiple visits. It's something that actually can be tracked remotely. If you've had a heart attack, heart rate variability may be very, very important. Heart rate variability, poor heart rate variability has been linked to air pollution. So it may actually give you a sense of whether or not air pollution is contributing to complications after you've had coronary artery bypass. In fact, one of the few examples that I'm aware of actual precision environmental medicine was a paper published in Europe where they actually took people who had had a lung transplant and they assessed air pollution exposure, and they showed that the mortality rates were higher if that person who had a lung transplant lived in an area of high air pollution versus an area of low air pollution. If I had a lung transplant and I knew that, I would move if I lived in an area of high air pollution. You know, that would be a big incentive to find an area of lower air pollution. And there's all kinds of measurements that we can get from satellites. So there can be air pollution, temperature, it can be exposure to green space. It can be daily air pollution. It can be traffic patterns, which represent noise. It can be access to healthy foods. This was a really interesting study that one of our faculty, his name is Itai Klug, did. Twitter actually has geospatial locations embedded in it. So he did a search on Twitter for mean tweets. And this is a geospatial plot of where the mean tweets were in the state of Massachusetts. This was pre-last election. So but just to show you that there's a lot of social media mining actually can be a big source of data going forward. So there's all kinds of big data that are very, very different than the traditional data that we've been collecting that are going to be relevant for exposomics. And this is, I believe, where the field of medicine and precision medicine is going to go in the next 5 to 10 years. So how do we operationalize this? We're going to be looking at wearable devices, measure activity, air pollution, temperature, physiology. We can address, we can actually, a physician may see you, may download your wearable device data, they give you some counseling on how much activity you've actually had. This is actually a much more objective than how much do you exercise and how much do you walk. It's actual data from the wearable device. He or she can download your residence history going back to childhood and get estimates of air pollution and built environment, other types of environmental exposures. If they have your occupational history, perhaps they'll do a job exposure matrix in the waiting room and get an idea of what kind of chemicals you've been exposed to, which can actually help inform an untargeted chemical assay that might actually tell you whether or not you're exposed to something. And if it's in the EMR, there can actually be other types of data like crime statistics, chemical exposures, and air pollution, all of which can be downloaded and work in sort of the background of the computer in the doctor's office to give you an idea of what your risk factors are for your health. So there's lots of barriers as well as these opportunities. One barrier is that clinical diseases are relatively rare most of the time. So we're probably going to need networks to have big enough sample sizes. That's not necessarily a deal breaker. Certainly NIH has a lot of experience in actually funding networks. Environment may be place-based. That is, air pollution is very different in the city than in the country than in the suburbs. Pesticide exposure is much more common, obviously, in some areas than in others. Lead exposure varies geospatially. So networks, however, may increase some of this geospatial variability because you don't want an environment that's uniform. You want some variability in that environment so you can understand the effect of the environment. Very few physicians are trained in environmental health or epidemiology. So they know little to nothing about environmental health. But most of them, quite frankly, think genetics is more important than environment. So it's going to require some re-education of physicians. But by the same token, public health scientists, environmental epidemiologists, very few of them conduct clinical research. They don't have easy access to patients. So that requires partnerships with physicians. And they know a lot about risk factors that cause disease, but they may know very little about how diseases are actually treated after somebody gets sick. So that actually fosters an incentive to partner. I would actually argue these partnerships can be very, very complementary for those reasons. And then this is such low-hanging fruit that I could probably do this all day. These are just some examples of environmental health precision medicine studies that people could do. Maybe you could measure indoor air quality or outdoor air quality in cystic fibrosis patients, how that affects severity and disease progression. Maybe you could measure environmental obesogens as a modifier of glucose control in patients with diabetes. So maybe one of the reasons why that their diabetes is poorly controlled is because a woman wears a lot of perfume that has a lot of phthalates. It's actually interfering with the glucose metabolism and their insulin does. That's actually actionable if that's the case. Maybe neurotoxic metals are actually more common in kids with autism. In fact, one of my examples is a 17-year-old who was lead poisoned. So maybe there's other neurotoxic chemicals that autistic kids are getting exposed to because of their pica that actually might be actionable, that might actually improve their long-term prognosis. It won't reverse the disease, but it can make it less severe. And maybe we can look at wearable devices to identify where you are when your asthma attack occurs. And once we know exactly where you are, because we have these physiologic measures, but maybe have some subclinical signs that we can measure from a wearable device, we can get a better sense of what actually triggered your asthma. So all these ideas are very low-hanging fruit. Maybe we should go into a surgical ICU and measure air quality. Maybe there's actually differences in mortality rates in different ICUs, in different rooms in an ICU based on the quality of the air. Maybe people with nephrotic syndrome, which is a chronic kidney disease, or who are exposed to nephrotoxic chemicals like mercury, actually have a worse prognosis. Maybe we can look at untargeted chemical assays to diagnose different types of eating disorders. Maybe toxic metal exposures are actually making Parkinson's disease progress faster. If you really think about so little has been done, I could probably make 5 or 6 more slides with just gratuitous research ideas, all of which have not been done. Exposomics is different than genomics. And I think that's why we in the environmental health world are going to be very valuable going forward with precision medicine, because it is a big data science, but it's not a single assay. It's not like DNA sequencing. It's not like GWAS. It's not like DNA methylation. It does involve assays. Untargeted chemical assays are certainly part of it, but some of it are things that are never going to be found in an assay. We can't measure noise in an assay. To this day, we still can't measure air pollution in an assay. So it's going to involve geospatial monitoring. It's probably going to involve questionnaires to a large extent. A job exposure matrix will give you some idea what your occupational exposures, not just exposures are, but whether you lift heavy items or not, all of which can be very, very important to someone's health. Mobile devices, which are linked to GPS, are also going to be very, very important in this field going forward. And all of these types of data are going to have to be integrated. And it may also include pictures. My daughter actually uses Snapchat to show me a picture of what she's eating every time she cooks a meal. What great research data might that be if we could get research participants to take pictures of their meals and send them to us? Maybe we could actually start to use machine learning to actually try to get a better understanding of the calorie content of their meals. So I have to give a small ad to the CHEER and HERE program. So CHEER is an NIH program. Mount Sinai is one of the sites. It stands for Child Health Exposure Analysis Resource. We're a network of laboratories. There are actually 6 of us that actually, if you have an NIH-funded study, if you send us samples after an application process gets approved, we will measure untargeted chemical assays. We'll measure targeted assays. Dr. Work, if you have teeth, we'll measure biomarkers in the tooth. It also includes metabolomics. It's evolving into a new program called HERE, Human Health Exposure Analysis Resource, which means that we're no longer only focused on children. We're going to include adults as well. So children are still part of it. So if you have a child study, it still counts. But adult studies are now going to move into the HERE program going forward. The HERE program starts in September. So sometime next year, we'll probably have the first call for applications for HERE, all of which can include randomized control samples or clinical studies as well. So in the future, exposomics and precision medicine are going to enable diagnostic tests, so we can identify subpopulations that might have varying prognosis, or just make a diagnosis in an unusual presentation, unusual cluster of symptoms and physical findings. We're going to have a better understanding between the relationship between environment and prognosis, and environment and treatments, including response variability that's due to environmental exposure, side effects that are actually being promoted by environmental exposures, and even issues like compliance that may actually be exacerbated by concurrent environmental exposures. Hopefully in the future, exposomics are going to complete this complex disease PMI puzzle. I'm very proud of this because I made this by hand on PowerPoint, puzzle, so I always try to sneak it into almost every talk. But I think environment is the final piece of the complex disease puzzle. And I think if we include it with genomics, and I'm not trying to say environment is more important than genomics, I'm trying to say that they actually are equally important. But if we're so focused on genomics, we're missing a gigantic piece of the puzzle. We'll never really understand what's going on until we look at them as an integrated measure. By doing so, we have to ask the right questions about treatment and prognosis and progression of disease, so that in the future, precision medicine will look more like this, where it's not just DNA, but it's other types of characteristics, including demographics and environment, so that we can actually truly personalize precision medicine and make precision medicine more precise. And that's the last slide.
Questions from the
let's see if this makes sense. Typically, when we look at environment disease, we think of environment as a causal factor. Now we're looking at disease, the probability of one current environment. How do we differentiate a lag period for exposure to a certain environment and not causation of it because of that exposure? But how does that lag affect exposure to environment?
I think I know what you're saying, yeah.
Affect a person whose disease probability one due to some other factor.
Yeah, so, I mean, some chemicals have really long half-lives, like DDT. And so I think what you're saying is it may have played a role in causing a disease, but it's still there after the disease is there. I would argue that once you have a person who has a disease, causation doesn't really matter, at least from a medical perspective, it doesn't matter so much. So if it's still there in the body, I would want to measure it in plasma for the case of DDT or any environmental chemical. I'm no longer thinking in terms of whether or not it caused it. I'm thinking in terms of what it's doing to the disease process that is clearly present. So if it's, say, Parkinson's disease, I'm interested in tremor, I'm interested in cognitive function, I'm interested in motor function, and I'm looking at whether or not person A with Parkinson's disease who has a high lead level has a more rapid progression, downward progression of their Parkinson's disease than person B who doesn't have a high lead level. Both of them got there, they may have got there through the same process, they may have got there through a completely different process to their Parkinson's disease, but at the point at which they have the disease, from my perspective, all that matters is what's it doing to the disease. And so I would argue that, yeah, it may have caused it, it may not have caused it, but that doesn't matter. If it's present when the disease is present, then I want to see what it's doing to the disease.
I'm thinking more not causing it, but the prior exposure has an effect on the disease itself due to some other causation, but there is, instead of a current environmental interaction with genetics, some kind of interaction due to exposure.
I see.
Not causation.
So the chemical may, or whatever the environmental exposures may be gone, so you can't measure it, but it's having an impact on the prognosis. You know, I think there are still ways to go back in time. All of those satellite models go back to whenever the satellite went up. So for some measures, you may be able to do that. In some childhood diseases, you may be able to do that with teeth. There may be, it's not perfect. There may be things in which, there may be cases in which that happens, in which we can't measure the chemical because it's gone, but it's still having an impact because it triggered a cascade of events that are still going on. That absolutely happens.
The treatment could depend on prior exposure.
It is. I think from my perspective, one of the reasons to introduce this idea is, while that may be the case, there is so much low-hanging fruit about concurrent exposures that we're not even ready to get there yet because we haven't done the easy studies yet. And there are thousands of easy studies that need to be done in the context of precision medicine and genomics. I personally believe that precision medicine, if it doesn't do this, will fail. Because if GWAS has taught us anything, it's that genetics, when it's just measured in isolation, doesn't predict very much. I mean, there are almost no examples of complex diseases in which the genetic contribution to the variance is over 50%. Almost all of them. Doesn't matter which complex disease I pick, it's under 50%. So if that's all we do, we won't actually identify ways to treat people better. I think we have to combine them, and precision medicine is clearly the future. And if it's going to work, this is the way it has to go. And the All of Us program is thinking about this. They're putting wearable devices on people. So, you know, I don't think I'm the only one thinking about this, but I think within the public health world, you know, I'm as guilty as anybody of accusing physicians of ignoring prevention, but there may be some truth to the idea that people in public health ignore people who are sick, because all we care about is prevention. And as our country gets sicker and sicker, it's a big piece of the population that are affected by these environmental chemicals, and we have no idea how it affects their disease. But that's a good point. I think what you described probably is going to be happening in some cases.
I really appreciated your call for partner research. I think it's very important, partnerships, but it's hard to build a partnership with a person across the hall who's working in your same area.
Yeah.
And you noted that a lot of physicians have no training in environmental health. And I think Phil Brown at Northeastern and Julia Brody at Silent Spring have a lot of data saying that environmental health literacy among physicians is about as low as you can get. So how do environmental health specialists, putting you on the spot, pediatrician, how do we start those conversations with folks who may not see, may not have the background knowledge to build up partnership? We have to do some educating up front and get buy-in on these kinds of issues. So how would you start that conversation?
The cynical answer is money talks. So if you are talking about an NIH grant that's likely to get funded, I think physicians will get very interested. I'm actually on NIHS Council, and I gave a very, very shortened version of this talk, 5 slides, to NIH Council in June. And I do believe that Linda Birnbaum's told me that there will be an RFA on this idea going forward. The thing about this idea is, from her perspective, she doesn't have to fund the whole thing, because most institutes are disease focused. Most, like aging, is focused on Alzheimer's and Parkinson's disease. So they will likely want to partner with her if the idea is studying environment on Parkinson's disease and Alzheimer's disease. NIMH is very interested in autism. So if we're looking at environmental risk factors for autism, they may partner with NIHS on that. So this, to her, is interesting because it gets her into precision medicine, which, as I said, has been very genocentric. The overall director of NIH is a geneticist. And so this will make her look good to him, but it also has natural partners. And I think that's one way to look at it, is you need them and they need you. And if there is good work to be done that can help patients, that's the less cynical answer, then I think it'll work. And, like one of the things I've pointed out, I think to Phil as well, is that when you're talking about education for environmental health, don't forget the pediatric residency directors, because they are all in medical schools. They all want to get promoted, and getting on an NIH grant is good for your promotion, and play that up, because that actually is that's a good way to incentivize them.
We are now over time, but thank you again. You've shared with us a national, vision, very forward thinking. So thank you so very much.